This is Dave Bender with Frank Rosenthal. This is the third case or the third hour in the basically the dry needling course we have here. This one, what we've done is we've had the article that everyone has had to read. What I do with this one's a little different. What we want to do is we want to take kind of a case example and maybe work through a case example, looking at it not only from the dry needling or central and peripheral sensitization lens, but from basically the orthopedic physical therapy lens. We kind of picked a really kind of a regular patient that you might see in clinic. So again, this was based on the article from Dry Needling, Peripheral and Central Sensitizations, which was originally published by Demeralt back in 2011. This case example that we're going to use today is going to be a recreational tennis player. We have this patient named John. He's 42 years old. He's an office worker and he's a recreational tennis player, plays about 3 times a week. He's had gradual onset of burning, aching pain in the medial calf, worsening with prolonged, tennis play and certainly after activity has been kind of his main complaint. This has been an insidious onset over the last 2 months. And it's been aggravated by quick lateral movements, pushing off during serves. He's noticed it. He describes this pain as, deep, like a burning ache in the medial calf with sharp pain during activity and loading. Some tenderness remains, at rest and afterward. His pain is worse after prolonged activity, with mild improvement at rest, but the pain still persists over time. Its aggravating factors are side-to-side movements, sudden acceleration, push off of the toes, and again, he finds relieving factors. He finds that compression sleeve helps, light stretching, ice and massage relieve his symptoms, but with no real, noticeable change over time. There's no numbness or tingling or localized pain, without radiating symptoms. Guess we can talk about, okay, what's kind of the typical thought process, what this individual's just described to me and what we're thinking,
Yeah, so
right?
in general, this is, making me think, all right, there's definitely some mechanical factors in play here, right? So, hey, worse with activity, better with rest. Although it's not totally better with rest. So in my mind, hey, there's going to be a little bit maybe of some sensitization. And we can kind of think about, all right, whether that's peripheral or central. Just off of this information, um, I would probably tend to say it looks a little bit more like peripheral sensitization. Um, that things are not he's not getting right now diffuse pain, but that burning and aching and mechanical sensitivity kind of lead me toward that peripheral sensitization.
Yeah, and there's that peripheral sensitization also think about that, I think the best term I've ever heard called is like a chemical stew, where it's that substance P, histamine, prostaglandin, all the other factors that go into inflaming tissue or sensitizing nerves that go in. There's that burning ache, that residual pain, yeah, we can think, okay, this person does have there could be an inflammatory component, but it's gone on an awfully long time to be an acute inflammatory component. But certainly, you could have some chemically mediated pain that's kind of contributing to that continued peripheral sensitization is the thing we consider. And this is a 42-year-old male, so he's a wonderful candidate for, a calf strain and these types of things because they're just more common. You get certainly tissue changes, the collagen makeup that happens, collagen changes that happen as we age would certainly be a predisposing factor. And again, this is almost, always you see exclusively kind of the medial calf. Couple reasons been proposed by it. I don't know the validity of this one, so this is just me quoting one article that I read. They talked about sometimes that the medial calf generating more power, but I've also read that the lateral calf may have more involvement in the vestibular balance coordination type motor outputs versus pure power. But again, that was one article I read from a while ago, but I always thought it was interesting in how it did. Frank, anything you've ever read on why the medial calf more than the lateral calf?
Other than that, no, I can't really think. You can kind of think
Yeah.
about maybe is there an impact with
Mhm.
off the top of my head, hey, is there a difference in fast twitch fibers in one versus the other, or is there a calcaneal position change? But otherwise, no, I can't think of anything else.
Yeah, it could be that, but dig a little deeper. Maybe hour 4 or 5. We'll
There you go.
dig into that a little bit more since it's been a
Update.
little while since I looked at that.
So if we think about this differentiation, how do we figure out peripheral versus central sensitization. In general, and in this case, the location of the pain is pretty much localized in the medial calf. So that's pretty consistent with peripheral sensitization. With central sensitization, you're going to have some widespread or moving pain. It won't be limited to just the calf. There'll be an expanded field. The pain mechanism, with peripheral, you have this sensitized peripheral nociceptors due to repetitive stress. And then, as you mentioned, that kind of chemical soup, the chemical stew that's kind of going on with those tissues, changing the depolarization threshold and the receptor fields. Versus central sensitization, all right, you may have some of those things, but then over time, you get this dysfunction in the central nervous system with pain processing, descending inhibition, and altered dorsal horn motor pool and activation.
Yeah, so something like central sensitization with these, it's like I look for something that was, certainly disproportionate pain is what I would look for. This person is sensitized, but I would expect, just a much larger, much more of a spreading over a larger area than maybe even the calf at that case if it was more of a central sensitization.
So then you think, all right, with that stimulus response, with peripheral, there's going to be increased sensitivity at the calf and some mechanical hyperalgesia. Again, you have that change with acetylcholine, with altered depolarization thresholds, and a little extra response to some normal stimuli versus central sensitization. You have this hypersensitivity. It extends beyond the original injury site. So this will be, hey, not just that medial calf, but it could be the low back. It could be the opposite side quad, kind of all over. And that again is that kind of descending inhibition and lowered pressure pain threshold that is centrally mediated. With the peripheral sensitization, the duration of the pain is going to be triggered by activity, and then generally is going to improve by rest. Again, there's still that mechanical component to it versus central sensitization. Hey, we've got this, one way to think about it is almost like a runaway pain system where this pain persists even without the mechanical input. Hey, things have been going on long enough that the central nervous system has been hijacked or rewired a bit to create pain signal without mechanical input. And then finally, the treatment. So peripheral sensitization, in general, you're going to improve with some local interventions. Hey, I'm going to treat that tissue, and whether it's manual therapy, dry needling, exercise, central, desensitization techniques, and things are going to improve. Versus central sensitization, you're going to, those things help and are needed, but you also need to have this broader neuroplasticity-based treatment. So, hey, this is getting into whether it's some diaphragmatic breathing, some mindfulness, some education, pain science education, some aerobic activity to help the central nervous system. Those things are needed for central sensitization.
Let's get into some of the further clinical findings. Certainly with outpatient, what we're going to find in John is that he's going to have a tender taut band, most typically in the medial gastroc, again, at the musculotendinous junction. It's usually where these injuries are going to occur is at that junction. And there's different grading systems for these level of strains and tears, depending on that. And we certainly have seen them, many times. Let's say this was an acute case where he was playing tennis and he felt the acute pop and this happened, and there's an inability to bear weight on it. It's a little bit more of an acute trauma. I mean, very commonly, sometimes, when you see these, the injury can be quite deep. It can be an inch and a half deep or so. So what you're going to see is that they don't even bruise right away. They may bruise 3 or 4 days later, and it may actually even show up at down lower around the ankle joint. So an acute case is going to look a little different than the one that's presenting at ours. Certainly, they're a little bit more straightforward. There's an event, and they're altered and changed. And again, those patterns can follow a little different course than the one we're seeing here today. With this also, we see referred pain upon sustained pressure over the myofascial trigger point. So many times what you'll see is basically peripheral expanding zone when, again, mild, input is given to that area. So it stimulates increased, you know, I want to say nociceptive input, but in these cases, it may not all be coming from exactly the nociceptor. If it's peripheral, yeah, that whole neural system locally could be heightened and excited. But again, if there's some up ramping at the dorsal horn, then you could also get some of that as well. Then we start talking a little bit more and getting closer to the central sensitization system. So that's why I was reluctant to say nociceptors, because what you'll find is that there'll be a crossover effect where, normal pressure stimulus that comes in is now being crossed over and stimulating the pain response, more centrally, the dorsal horn or spinal cord or anywhere along the chain. Now, we expect to see with resistance testing here with plantar flexion, it could elicit sharp localized pain, in the calf muscle when being tested in neutral, is what we'd expect in an acute case. Now, in case of like tendinosis or chronic things, you can still play on this. I wouldn't be surprised to see that, hey, this isn't positive until I put it into the lengthened position of dorsiflexion and then do my resistance testing. Basically, your kind of classic Cyriax active, passive, resistive testing model will be one where, hey, he comes in here, I test him, and he's relatively strong and neutral. It's not enough tension on the system in that individual to elicit the pain. In his case, it is enough to elicit and reproduce the pain symptoms. But if I were to test this person and find that, hey, I test them in neutral, I'm pushing on them pretty hard, I don't get it, I want to test them with more tension, which may be something as simple as doing a single leg calf raise or heel raise. You know, Again, neurodynamic testing, straight leg raise, is negative. And that helps us just kind of, as part of our bias correction, rule out what could be, okay, radicular in origin. We're thinking, okay, this looks clear like like it's musculoskeletal, it's peripheral, but at some point in there, it's always healthy to go back and do a little bit of bias correction just to make sure that we're not jumping, to what they'll call premature closure, in your bias corrections, that I'm not just deciding, okay, this is what it is. I fail to look for anything else. So somewhere within your system, you can think of, okay, what would be the next most likely competing diagnosis? Okay, could this be a radicular case? In that case, straight leg raise, and probably TAs and biomechanical pressure over the lumbar spine is probably what I would look to do if I wanted to kind of further screen out that lumbar range of motion would be another thing you could look at as well to say, okay, do I see any type of lumbar influence on this pain pattern, and does it change my differential diagnosis? You know, we look at gait assessment here. What you may see is a slight avoidance in the push-off phase on the affected leg. I've seen them just have a very limp ankle where they turn it off. You can see them almost pre-tone or lift from the hip versus pushing off from the foot. So it'll change the gait cycle because they're going to move around it a little bit. So you can see, okay, I'm going to kind of shut this off so I'm not generating tension and storing energy in the calf as I walk, or I can use a substitution strategy. An interesting thing with the gastroc, even the soleus, they are the prime movers during gait. And the contraction is largely described as being isometric to a degree. And what lengthens is the serioelastic elements in the tendinous system. So during normal gait, there's not a great deal of muscle shortening and lengthening going on. That length is that stored potential energy in the tendon, which is then released when we come off. Muscles like the gastroc and soleus act more like tension regulators, if you think about it that way, to the serial or parallel elastic elements to regulate the tension for that efficient, transfer of energy. During that quick push off and those quick loading motions, then you're going to have more of an eccentric loading moment as we start to get into 3 to 5 to 8 times body weight for tennis type activities. So the stress thresholds in there are certainly much greater, i.e., why we see the strains with those activities.
And this comes into play, especially later in the phases of rehab where, hey, we need to get back in and stress those tissues at that level. You can't just finish up with heel raises and call it a day. Once the pain is gone, you have to expose them sequentially through those higher level activities to get them to get John in this case back to being able to play tennis without putting too much strain through that Achilles. So
Yeah,
when
good,
you're looking
Frank.
at peripheral sensitization, this is a hey, you can do some testing here. They make some little meters you can use to look at the pressure pain threshold. In general, what you're going to see, what we talked about in the first hour, was you're going to have that lower threshold over the trigger point area compared to the contralateral side. Hey, you put a force through its pressure on the affected side trigger point. It's going to be an earlier or a lower threshold to be considered pain. And also around that myofascial trigger point, you're going to see increased pain sensitivity, just a light touch. So, hey, even before you put any real pressure through there, there may be some sensitization to just plain old light touch.
And you said, many times these people have, you can have your dysesthesia, which is that, okay, it's an odd sensation they get. It's not necessarily pain. It's a dysesthesia or an awkward notion. There's hyperesthesia, which is an increased response to pain. You're typically not going to see an anesthesia, which is the absence of pain. Typically won't see that unless you have a, peripheral nerve injury, be the thing. So a couple different terms you'll see used for it. Which I won't don't expect to see with this is radicular or maybe lancinating pain, which would be more caused by the nerve root or nerve compression. If you have that now, not saying that you can get central and peripheral sensitization, the chronically irritated nerve, but I want to differentiate nerve pain per se from maybe some of the central sensitization or the heightened awareness thing. So these things certainly can coexist, but it's kind of thin slicing. Okay, when I have pain, it's coming from mechanical hyperalgesia. Okay, what am I actually seeing in the pain pattern? Again, part of that bias correction is make sure it's not a neuropathic type of pain. If it is, do I have neuropathic pain along with a peripheral or central sensitization, which is not
Yeah.
atypical. Treatment
All right. So
planning
as
with a
we
go ahead,
Oh, go
Frank.
ahead. All right. So, all right, we've kind of gone through getting our subjective, gotten our objective, and kind of come through our assessment of, all right, this is where this patient's issues are. Again, to sum it up, it's, hey, there's a big mechanical driver. However, is also a peripheral sensitization. So, thinking about how we're going to treat this, um, one way to go is to integrate the dry needling and some peripheral sensitization management, as well as addressing the mechanical issues. So for dry needling, for that trigger point, obviously the primary muscle we're going to go after is the medial gastroc. You know, with this, and we can put up some videos of this as well, but you're going to think about um, avoiding that central calf zone to avoid the tibial neurovascular bundle. Kind of going in at a 45 degree angle. Um, you can choose to do some pistoning if you like to get some of that local twitch response. Um, and also, depending on the pain and sensitivity levels of the tissue and the patient, you can even do some stimulation with this. Um, I would also look at some secondary muscles. So the low hanging fruit here is the lateral gastroc, but you can also think about the hamstring, soleus, and then that deep compartment, the posterior tib and the peroneals. All of those muscles, if you think about the gait mechanics and moving through space with tennis, all of those muscles are going to be called into play. And he's been moving on this for a few weeks and a few months. So some of those other muscles may have some increased tone, which are kind of perpetuating poor movement patterns.
Yeah, I mean the brain remaps pretty quickly with pain patterns you find. And your new aberrant pattern of movement around this to decrease that pressure threshold can certainly start to overload some other things as you change it. So you're gonna find sometimes there's the collateral damage. That is that okay, my cortex is remodeled a little bit, I've changed my gait pattern, I'm using different muscles in different ways, and it's out of sync. It's not their normal job. So you may find these secondary strains or these secondary taut bands, which is really good to clean up because it'll help desensitize that area faster. Also get, that neurological input into that segment, kind of say, "Oi, okay, this is, I didn't realize this muscle was toned." Let me kind of blow the fuse box, as it were, in those areas we're going to see. But certainly your area, the medial gastrocnemius tendon, that's kind of where it's different. Where this guy's a chronic case. If he's coming off the tennis court and it's a day afterward, probably some needling models out there for it, but I've not seen the research on it that was really strong to say, hey, this has a super great impact on the very acute case unless you are then treating some of these secondary muscles which are being facilitated and irritated, by the medial gastroc tear. So needling, there'll be a schools of thought of needling quickly. There's also, which may be more neurophysiological pain management versus healing potentiation at that point. Because of the level of inflammation in the acute case, you're probably not going to quite get the return on your time that you would with a more chronic case like this. Again, the idea of, palpation, we talked about active trigger points, those spots that are painful and sore before you touch them, you poke them, they're certainly sore. Your latent trigger points, your secondary points are those spots that, hey, he didn't know it was there until you put pressure on it. Now that spot is pressure sensitive. Those are kind of more known as your latent trigger points. They aren't actively painful. They're just stimulated upon pressure. Again, here, insertion point, and we'll add in some other areas on images on this. But as Frank talked about, we're going to angle away from the neurovascular structures, as a good technique. And there's different techniques you can use. There's, certainly pistoning is a technique that's very common. It's a short in and out motions to elicit the local twitch response. The idea for trigger point needling is that this pistoning response, what they want to do is create enough micro trauma to basically get this muscle to completely relax, to completely give up. So it could be pistoning anywhere from 10 to 15 times. That way, there's a twirling technique where you actually spin the needle, and that's been shown to kind of, okay, are you wrapping the muscle fibers and the fibrous tissue around the needle? Also, again, the idea of creating a little bit more stimulus to the neural system, but then also a little bit more micro trauma to maybe elicit that local healing response, that local increased blood flow that we've talked about in the previous lectures. So pistoning is a common technique that's used. The twisting, again, some articles will really support the pistoning technique. Other stuff, it doesn't really change outcomes. That part is still somewhat debated in what we're doing. I think, again, if you want an early thought on it, I think if you're looking at a purely muscular trigger point, and you're treating just a muscular trigger point, then that pissing technique is going to be a much stronger input and much more micro trauma to that area, and is likely to shut that area off. Then also that micro trauma increases blood flow and vascularization in that area. So is it that micro trauma that's part of the healing response? If this is more neurally mediated and I'm trying to down ramp the neural system and the neural response, then many times I'll use more of a needling technique that may be improving with using stimulation. So if you're in an area where you can use electrical stimulation, that's very good for stimulating this central nervous system that we've talked about in the previous lectures as well. Post-needling care can range from anything from light compression to soft tissue, area to reduce soreness, again, manage any complications that may occur after this. Bleeding and bruising is probably the most common one you're going to see. Some residual soreness may be the other one. So your light compressive technique or gua sha or an ASTEM or instrument-assisted soft tissue technique sometimes can help decrease some of that sensitization as well, increasing blood flow to that area. So if you're going to combine it with one of those other techniques, that's not an uncommon kind of package. Passive stretching. I got a little rub on maybe the word stretching. I like to think of the idea of active lengthening. So, what am I doing to actually more think about lengthening? Because stretching has this connotation. I'm taking it to its end range and I'm at its barrier and I'm applying a great deal of overpressure to it. Well, really what I wanted to restore is normal lengthening of this muscle. Get the neural system used to being able to go to this normal length. It can tone and lengthen at the same time. So I want to restore the nervous system's acceptance of that lengthening. Again, active movement to decrease to altered patterning. Again, we want to try and restore normalization of the normal gait cycle and muscle activation patterns as quickly as possible. Again, one to avoid collateral damage or developing basically the limp when you don't need the limp. Because at that point, you are loading tissues out of phase most commonly, and you're going to end up with something else down the line. And common one would be like I maybe see somebody with a gastroc strain, or they can be coming in for tennis elbow like 6 months later. And usually my fourth or fifth question is like, have you had a lower extremity injury in the last 6 months? Because invariably in a lot of my tennis players, the answer is going to be yes. And that altered pattern of movement that kind of persists after that injury, what they do is they don't take the extra step. They don't load as quickly. So doing that now, they load through the arm more. So instead of loading and pushing through the body and the lower extremity, this person is now driving through the elbow, and the elbow can't hold up to that much level of stress. So not an uncommon thing for me to see is that somebody with an upper extremity injury to understand, hey, did you have this gastroc strain, last year or in the last 6 months? Many times I'm bumping into somebody with a hip issue, a back issue, a knee issue, something going on in the lower extremity in that period of time, which changed how they're moving to irritate the elbow.
The next phase I would go into would be that sensory modulation for peripheral sensitization. This would again would be the same um, in the same session as that first dry needling. So thinking about desensitization, there's some really great things. Graded exposure is fantastic, both for central and peripheral sensitization. Um, in this case, we're going to do some graded exposure to mechanical input. You can do some light rubbing, some vibration over that area. I'll oftentimes use a Theragun or a Hypervolt or similar modality over that area. Um, it's going to do that graded exposure and kind of be light, very low mechanical input, and it also plays in with proprioception training as well. Um, certainly some people will do some, alternating warm and cold to try to modulate or alter that nociceptor activity. Um, there's some research on some short-term effects of that to then allow you to do some more loading. And then you think about proprioception. So, hey, John's had a couple months of altered loading patterns, altered balance, altered activation. So we need to expose his nervous system, both central and peripheral, to proprioceptive information to help kind of course correct and get all of the people talking the same language. So we're going to do some balance drills that first day. It could be as easy as a single leg stance with some perturbations. Hey, maybe we'll do some tennis ball hitting while he's on one leg. Make it, as fun or as complex as you want. But in general, the goal there is to restore that normal sensory motor control.
Or you think of dry needling, the idea is okay, hey, so am I dry needling this person before I do this? Am I doing it, after as a down ramping technique? And that's kind of where comes the idea of where are we doing it and why are we doing it? If I have a facilitated region of muscle or a fascicle that I believe is tight, it may be more of a strategic, I've done this, with runners, where it's more of a strategic needling at the front end of the session. Like I'm going to do it there, and I'm going to use several needles. I may piston greatly with this. What I want to do is here's that fascicle in the gastrocnemius, or maybe I find one in the posterior tib, which is not uncommon. I needle these 2 points or several small points, and then I get into my desensitization and these graded exposure techniques and my movement-based education. Say now, if I release this point, do I get a better job of retraining the nervous system? Hey, get them back on the treadmill and run if they're a runner. In John's case, probably gonna have them come off. One do light loading, some isometrics, but then it may be doing okay balance drills or doing his his ready position. The set position is one of a plyometric hop that moves into a second plyometric hop. So how does that change in his case if this is really kind of a myofascial trigger point that's bound down and I release it, how fast does that release occur? If I'm doing this for more of a neurophysiological pain modulation or that peripheral or central sensitization, and I tend to do it at the back end.
Mhm.
Or maybe I do this more prolonged needling at the back end where now I'm going to needle, maybe I use electric stim. Maybe I leave them in there for about 10 minutes or so, which is, again, several articles that say that's about the time where there's this point of diminishing return. Maybe that you're kind of getting your most benefit from that period of time and leaving them in for 30 minutes doesn't give you much more stimulation in that central nervous system. So something like this, I may do it on the back end if I need to use it as a down ramping technique. And that's the difference between using it as maybe a mechanical technique versus a neurophysiological technique. But it may not be uncommon in a session to maybe, one, I'm going after the trigger point, two, I want to down ramp the neural system. So again, there's these cases here. Let's assume this case, probably what I've done is, okay, fairly cute early on. I've probably done strategic needling. Okay, here's the point. I have it here. I can release this point. I can change his pain threshold. I can improve his lengthening. His isometric testing improves after I do this. So early phases, talked about isometric holds. It's calf strength without exasperating pain is not an uncommon treatment. I'm big on isometrics. I think they do work. I think a lot of isometrics have been shown, especially with the patella tendon, to down ramp and central pain for up to 6 to 8 hours. So they use it in basketball players as a way to down ramp them pre-practice or pre-game. That's how they looked at it in several studies. So the isometric system really good to kind of, as we're now operating again in that central system with this, but it's a nice way to also desensitize the tissue early on. And also, you can also, as you go on in your mid and later phases, they can very much be used for strengthening of the musculotendinous system. So my isometric holds may be body weight in the early phase. I'll do running isometrics in my later phase, which I want to be at 70% plus of, my one rep max, as I call it, or my capacity. And what they find is that by doing the isometric holds at that higher range for longer sustained holds, and even sometimes what you get up in there, many times you can do a series of 10-second holds. That helps not only maintain strength in athletes, but it will over time help to improve and strengthen that musculotendinous system. So a lot of good stuff out there on isometrics to be used. And an individual like this, it's probably a really good place to have an isometric component in your early, mid, and late stage rehabilitation. Yeah.
Yeah, I would definitely use that kind of throughout the stages. Can be used kind of mid stage to help calm things down or kind of activate things, and even in late stages like, as a warm up before getting into some sports specific things. The other thing I like to think about, just from a holistic standpoint, starting in the early stages. All right, as we're managing these symptoms with isometric holds and some soft tissue things at the calf, hey, let's think about, can we address the proximal muscles as well, muscle and joints. So can we make sure that the hip is staying loaded, and we're addressing any abnormal motor patterns that have developed, and preventing any atrophy up the chain as well.
You can see, okay, moving into eccentric phases, you can see here how we are going to, just move through the different phases. Closed chain, dorsiflexion mobility drills to restore range. Sport specific drills, certainly looking at your lateral hopping and doing things of, progressive graded loading, increasing the thing. And somebody like this as well, we got to think about who do we have, what's the likely mechanism. Now, I can I can tell you with many times that here, if we have a 42-year-old, one thing I do teach them is a balanced foot approach. What many people have is they're a little bit left of center in what they're doing, and that's why they're getting injured. I find many times it's non-optimal loading mechanics. Most common one for this person, which I can almost guarantee that they would have, would be that when he's loading on his forefoot with his heel off the ground, probably leaning forward in a dorsiflex position. So he doesn't have the hips properly loaded to push off from the hip. So if his heel's off the ground and he goes to do a first push, he has to now reload the gastroc soleus, tendinous mechanism because it's not optimally set. And what they do is they dorsiflex their ankle. They just lengthen through the ankle joint without storing energy. So that it really disrupts the stretch shortening cycle. Plus, the heel off the ground, their first push can't come from the hip. So when I teach someone like this to load with this medial gastroc strain, the most common thing that I'll encounter is that, hey, I need to get their heel touching the ground when they're in their initial contact. So I want that heel on the ground. Their forefoot should be loaded. The weight should be on the ball of the foot, but the heel should be in contact with the ground. So when they go into that first push, there isn't this eccentric or long lengthening moment that occurs as they load the forefoot, get the heel to the ground, or the heel wants to collapse to the ground, and then they push. Now they can better and more optimally drive from the hip in a balanced manner. So whether it's lateral cutting or this first push off, this is one of the more common things I see because tennis coaches and everyone tells you, hey, get on your toes, get on your toes. It's like for many sports movements, especially once you're in your 30s, kind of would prefer you to be where your weight is on the ball of the foot, but many times the heel contact is an optimal mechanic for direction change. And it allows you to really kind of get into your larger muscle groups, during your first push versus your load just through the gastroc soleus. That's one of the more common mechanisms I will see in this individual. So it really is about a re-education in their early setup, and then that first plyometric step that they use. and how they push, and getting a sense of how do I transfer that load to my hips away from my calf. Just thinking, oh, I'm out of control here. Give me a second here. Oh yeah. Also put in here biomechanical interventions. It's really kind of another important thing to talk about is that, at early stage, I want to address any biomechanical drivers that are there. Common things that contribute to this would be a subluxed talocrural joint, an ankle joint that won't dorsiflex, and they lose the lateral conjunct rotation of the talus. I can have a subtalar joint. My subtalar joint is innately tied to my Achilles and my gastrocsoleus mechanism. It's supposed to, in that mid-leg phase of gait, those muscles, the tone of that muscle pulls the heel back into inversion and allows me to lift my heel up and lock my midfoot. If I have a subluxation in my subtalar joint and it's everted, it's going to really add strain to my gastrocsoleus mechanism. So understanding what the subtalar joint is doing, one in gait, and what it's biomechanically capable of or not capable of, will tell me a lot about the demand that's being placed on the gastrocsoleus mechanism or an Achilles tendon in that case. So this person, if it's sublux and eversion, they can't lock the midfoot, they can't store energy. They're going to pull a lot harder to try and get out of that system than an optimally aligned subtalar joint. So super important in really understanding why I have the trigger point and why I'm developing this injury. Because that would be a very common finding, posterior tib finding, peroneals. You could find any one of those lower extremity drivers in these biomechanical dysfunctions. Hip positional fault. If this person is living with their hip mildly anteriorly translated or anteriorly medially rotated, certainly going to affect the hip rotators, and certainly, you're going to see your hip impingement type symptoms with this as well. But it's also going to change, forces as they go through the ankle because it's kind of a tendency to drive the leg probably further into internal rotation from an uncontrolled internal rotation moment, driving the heel into eversion. Maybe you're again causing an increased calf strain because it's harder to pull out of this mechanism. So I changed the optimal loading mechanic of the gastrocsoleus mechanism. So manual therapy there, that those are your biomechanical and certainly your manual therapy techniques for desensitizing not only the local tissues, but also, you find that again, they manipulate the thoracic spine, they decrease pain pressure thresholds like in the foot or in the hand. Those studies have been done. They're numerous out there. But you'll see, not only local, but, systemic effects. And I think you also see very similar responses with needling, i.e., that you needle a certain area, but you may find that you've regulated pain in other areas of the body, which occurs. So there is that more, even though we'd say we're needling for the peripherally mediated effects here, there will be centrally mediated effects as well. And that will vary from individual to individual and their level of sensitivity to that. Mid stages, okay, if it's a biomechanical dysfunction, ideally I cleaned up the biomechanical dysfunction that I could with subtalar joint manipulation or talocrural joint manipulation. Now I need to be able to proprioceptively train them to have the proper motor control to maintain optimal alignment. So I may be doing my proprioceptive input of a subtalar joint MOB or talonavicular joint MOB, prior to then doing my neuromuscular reloading. So many times that's rolled into my neuromuscular reeducation as a facilitatory technique, using that joint glide and then going into my motor pattern retraining. Or I'll do the joint glide and see, does it change my trigger point sometimes? Sometimes, maybe this person doesn't want needling or they're not appropriate for it. Treating from the biomechanical model and the neurophysiological model here. It's not a bad way to go to say, hey, listen, I can down ramp some of that posterior tib or that medial gastroc tone, through this peripheral manual technique by stimulating the joint. You see it all the time with spinal joints and manipulation of the spinal joints. You can change longus colli, longus capitis, sternocleidomastoid tone with a cervical manipulation. Good news. Bad news is sometimes because you didn't treat the biomechanical faults that may be driving it, there's a tendency to creep back in over time. So again, that neuromuscular retraining becomes this becomes creating a window for optimal neuromuscular retraining. Again, desensitization, as we talked about there. And again, late phase would be proprioceptive input to facilitate return to support. Ideally, I don't need to keep manipulating this joint because it doesn't keep subluxing. If it does, there's a biomechanical fault, likely somewhere else in the chain. or they have a hypermobility. And this is the way their body establishes stability, is by taking this hypermobile joint and jamming it into a position of stability. In which case you'll probably know because they'll be in more pain after you treat them. You fix their hypermobility, their instability, or their subluxation, and they have more problems down the line. You realize, okay, this was a hypermobility that was finding stability.
Mhm. So you think about dry needling, as we've discussed, there are multiple targets for dry needling. You have these local tissue responses. You can have the centrally mediated things, which incorporates spinal cord, brainstem, and cortical levels. All of these things lead to ultimately pain relief or assist with pain relief, neuromuscular function restoration, and sensory motor system modulation. So if we think about, again, just to kind of briefly dive in again to that local tissue response to needling, um, these are things that happen in the tissue that is being needled. All right, the needle penetrates this dysfunctional motor end plate, um, and it kind of, breaks this excess acetylcholine cycling. Oftentimes you can see this sustained sarcomere contraction that then gets interrupted and broken. And you also can have this, we talked about in, I think, hour one or two, the local ischemia from this sustained contraction. So this mechanical disruption of the needle helps to break those things as well. Um, the spontaneous electrical activity in general is not going to, at rest is not going to happen. But with these myofascial trigger points, these active trigger points, it's going to happen. So this needling is a great way to mechanically disrupt this. The local twitch response, we're going to utilize the spinal reflex arc at that segmental level. You're going to get this rapid depolarization of the muscle fibers, which again is going to, as I mentioned, is going to help normalize this acetylcholine release. Um, and oftentimes there's going to be a refractory inhibition of excessive end plane activity. Hey, this is the person that, hey, they only have a local thing going on. You do the needling, and they're going to feel fantastic right away. Hey, if you repalpate that myofascial trigger point, things are going to be much less tone, less taut bands. Now, if you think, okay, they're fixed, and then you don't treat the system like we talked about before, the biomechanical factors and the muscle loading, this is going to come right back. So you need to take advantage of this refractory inhibition and then follow it up with some motor repatterning. Um, Needling also has been shown to stimulate some fibroblast activity. So, hey, for those tissues that have been pathologic for a few weeks or months, we're going to improve tissue hydration and this extracellular matrix remodeling. So you're getting into local healing responses. Biochemical and inflammatory effects. So in general, you think about, all right, we have this um, biochemical soup. Try needling, one way to think about it is it is a biochemical washout. So you're going to have a decrease in substance P, um, bradykinins and interleukins at that needling site, which is ultimately going to decrease local inflammation and hyperalgesia. So all the pro-inflammatory mediators tend to get washed out. At the same time, usually within a few minutes, you get this upregulation of the anti-inflammatory cytokines. So interleukin 10, the endorphins, and the opioid peptides, promoting that local pain relief. Um, Additionally, because of nitric oxide release, you tend to see vasodilation, which improves the tissue oxygenation and reduces that ischemic condition in the muscle. So, pH gets normalized, oxygen delivery is improved. I'd say these several things are why the patients, feel different the moment you needle that quote unquote right spot. The biochemistry is changing both immediately and in the minutes after the needling.
Yeah, and those about too. There will be those people where, okay, you're needling, certainly with your pissing techniques that are more aggressive, your pain response will go up because you're creating inflammation at that site. So I usually hedge my bet with this. The best thing to do is I'll explain to them, hey, listen, you may have a little bit of increased pain or irritation over the next day or 24 hours. I expect it to go away. What I like to see is that in like 2 days, oh, there's a big difference in that washout effect. So it's always good to prep them for, hey, what may be the worst case? Hey, if you feel great right after, everything's great. This is awesome. You have nothing to lose by prepping them that, hey, in some cases, there's a little inflammatory response, but what happens is on the rebound end, you're way better because you may be inflamed for a little bit, but then as your body recovers from that, it does a better job of locally inhibiting the pain response. So by the time you get to the rebound, I think of a patient that you squeeze them in on a Friday afternoon because it's usually a guy like me who's put it all for 3 or 4 days or 5 days. So it's end of Friday. Now he wants to do something about it. Squeeze him in, you treat him. Okay, maybe it's a lumbar spine patient. Manipulate a joint, needle the multifidi, that they leave there, they're better. They're not like where you'd want them. So you leave there on Friday feeling kind of disappointed, like man, I didn't fix him and feeling bad about it. But then when I hear from him on Sunday or by the Monday, it's like, oh no, I was a little bit better that day and sore. I felt better Saturday, but by late Saturday night, Sunday morning, man, I really felt great. I started to feel more normal. Now my pain is 10%. I know that, yeah, I got the biomechanical dysfunction, the needling down ramp, some of the symptoms. You'll see that delayed response sometimes. So I'm not as disappointed on Fridays anymore when I do that as I used to be because I know that, hey, there's a good chance probably going to get better there. And if I tell them that that's what's going to happen and it happens, the nice thing is I look really smart. And, it's always nice to look smart when you're just kind of, taking an educated guess, let's say. Centrally mediated responses. You know, with this, dry needling activates pathways within the spinal cord, brainstem, and the higher cortical areas. We kind of showed that in that complicated diagram, going back to the first thing that, there's multiple areas where we're going to be able to modulate pain response, much like there's multiple areas where that pain response can be upregulated, in individuals we see. These are the areas that we can kind of, get about it. And here's just some of the things. So segmental inhibition, they talk about the gate theory. We're going to stimulate, different mechanoreceptors. You're going to inhibit, nociceptive C fiber, A delta fiber activities, input at the dorsal horn. So that gate control theory right there at the spinal cord level and the dorsal horn. The descending inhibitory control, and activation system, they talk about different things. The opianergic, which may be more your non-specific pain modulatory responses that you see, i.e., explaining a lot of that why they feel better in peripheral areas. That when you needle the lumbar spine, but they feel more relaxed or the pain tends to go away, or maybe it's like, oh, I feel better overall and move well. That's being modulated, anywhere from the brainstem, dorsal horn, reducing nociceptive transmission would be one. But the other one could be the non-specific or the systemic opioinergic effect. Several studies, back, coming out of China, they talked about how they would, they would basically use acupuncture as a form of dry needling, and they can needle one rabbit, and see that this opianergic effect would happen in the cerebral spinal fluid. Take that CSF fluid and inject it in another rabbit and modulate the other rabbit's pain. So it's just kind of interesting things that they can kind of do with it. Another sidebar on that one would be that I think they've also showed in that in some studies, and I'd have to want to look at this again just to make sure this isn't updated, but they used to see that you needed an intact neural system to do it. So if they deadened a nerve and they try and needle that area, they would not see these centrally mediated responses because you're not getting that signal into the central system. Again, neuroplasticity in the sensory nervous system organization. Dry needling, what we're really hoping to do is to normalize the maladaptive spinal cord excitability, often seen with central sensitization, and that persistent pain in these pain states.
So
Brainstem,
you think,
autonomic. Oh, good, Frank, you want it?
sure. So you think with the brainstem, all right, we're moving up now in this autonomic nervous system response. Um, I'd say you have kind of three things to think about. You have this periaqueductal gray activation. So This is going to help coordinate this descending pain inhibition, and it also integrates the threat modulation. Again, you think about it evolutionary wise, nociception is really just threat detection. So, it's tied heavily to this kind of threat and fear avoidance system. So training has been shown to decrease this or to alter the PAG activation through this opioid pathway. The the next thing is really the autonomic system um, modulation. So sympathetic nervous system, it's going to reduce that sympathetic tone or overactivity, acting through the hypothalamic pituitary adrenal axis, the HPA axis, and is going to decrease this catecholamine release. So again, you're going to think about reducing this systemic or sympathetic overdrive, which is locally then going to improve local blood flow. It's going to improve the tissue healing capacity and even and shift you more into this recovery state as opposed to the fight or flight. Um, and this is kind of some of the mechanism for at one level, higher level of reduced guarding, improved post-treatment tone, and this decreased secondary muscle co-contraction. So hey, our hamstrings are soleus. Hey, that there's this co-contraction happening because of these altered patterns and this threat. This sympathetic down ramping is a great way to modulate this. And
Mhm.
then finally, you think about the reduction in hypervigilance and threat perception. Again, the amygdala is really tied with this threat perception. So dry needling has been shown to downregulate this activity and reduce this pain-related fear and autonomic arousal. So the cortical and brain responses, think about the primary somatosensory cortex, the S1 modulation. Um, you know, Chronic pain leads to this cortical smudging we talked about with the functional MRI. So the borders between areas gets kind of smudged, like you've poured water on a piece of paper with ink. The ink gets smudged. Dry needling has been shown to reverse this smudging or maladaptive neuroplasticity in chronic pain conditions. Um, we're going to more accurately represent the body, this homuncular organization, which again, trineedling followed by proprioception is fantastic at kind of rewriting this. Um, so for this case, for John, hey, even though he's more of a peripheral sensitization case, this dry is still going to help restore this discrete representation of the calf. Um, so then you think about the motor cortex, so M1 recruitment changes. Pain inhibition really suppresses this plantar flexion output. Um, and so you have this inhibited motor output and altered movement control. Dry needling is going to then normalize this recruitment pattern, especially any inhibited or atrophied muscle. So motor drive, force output, and coordination timing is improved. One of the things that there's a great article looking at in the article, it's Achilles tendinopathy about how, hey, we do a pretty good job of rehabbing this. However, there's still an increased risk of recurrence, and the authors postulate that this is due to some decreased cortical drive even after a course of PT. So what they look at is some studies showing uh, doing heel raises, concentric and eccentric, to an external auditory cue, so a metronome, and actually doing the heel raises this way with this external cue compared to just your own timing with heel raises increases the cortical drive. So it's a great way at that mid and even later phase of rehab paired with dry needling to do this motor cortex reintegration. So improving cortical drive to the calf muscles, the plantar flexors. And then finally, for this cortical and limbic effects, you think about the prefrontal and limbic system changes. So this gets back to, and again, that emotional and pain perception. Training has been shown to increase the anterior cingulate cortex, prefrontal cortex, and insula, which are all responsible for this cognition and emotional regulation. The amygdala, there tends to be some hyperactivity. That'll be decreased. Threat perception reduces, and oftentimes the patients, hey, this is a way to help them move with less anticipatory bracing. And then neurotransmitter regulation. So we talked about the opioid release already, the serotonin and the dopamine. All three of those really help with long-term pain release.
Here, it's, we summarize this a lot, but, I know this is a lot, this is new for a lot of people. So it's kind of good to kind of keep going over it in your mind because eventually you're gonna kind of take this down and be able to kind of explain it to patients or at least kind of understand what you're doing within the clinic. Some are responses at different levels. So, within the local tissue, there is disruption of the dysfunctional, motor end plate. That aberrant motor end plate activity, gets disrupted. One of the things they found with like trigger points from, acupuncture and the trigger points from like Trevell and Simons, that one, they overlapped a lot, and two, they found that it was usually at spots where there's increased, neurovascular input or neural input is what they saw. So this motor end plate activity, a decrease in this local twitch response or this hypersensitivity to the muscle in the treatment. They do see increased blood flow and oxygenation, which is that idea of potentially flushing out these histamines and prostaglandins and that, that chemical stew of irritation, as it were, and that decrease in inflammatory cytokines that occur in the local tissue response. At the spinal cord level, I mean, we're all familiar with the term the gate control theory of pain, and how this inhibits nociception. Its impact on descending inhibitory control, which could either be from the opioid system, serotonin or noradrenaline pathways that raise these pain thresholds that occur. Normalization of spinal excitability and maladaptive neuroplasticity you know, just as it's stimulating that pathway to kind of reset that excitability from that chronic nociceptive input or that input that should be normal sensation that is now being perceived as being or transferring over to be perceived as being nociceptive. Certainly the brainstem, the PAG is implicated in activation with descending inhibitory pain control. There's modulation of the autonomic nervous system and the sympathetic, response and regulation. And there's also this reduction in hypervigilance and perceived threat, which kind of helps, which is, kind of getting into that idea of, that kinesiophobia or that potential what keeps them kind of in a guarded or aberrant firing response because it's the protective reflex and resetting that at the brainstem level. And at the cortical level, we're talking about restoration of the somatosensory and motor cortex function, reduction in limbic system hyperactivity, that fear and pain modulatory component to that. And we're going to increase the endogenous opioids, serotonin, and dopamine release, which have that central pain modulatory control mechanism. So it's kind of nice because as we're treating, it's like, we have these different gears. And I can't say I always know which gear I'm best operating in, but I know when I'm treating an individual, sometimes I kind of know what I'm going for, in a sense of, okay, is this a very strong, they've had this for a while. There's a very cortically driven response. There is an emotional response to this. I have some limbic system drive or an autonomic drive. I know that maybe I want my treatment to be operating more in that central system. Can I steer that in my favor? Certainly a local tissue response. This is a hypertonicity in the tissue. This tissue is wound up. I want a local response to down ramp some of that tone, whether it's at the spinal cord level by decreasing the pain in that gate theory, and I want to reset the spinal cord level, maybe stimulate some descending inhibition if I have a tight fascicle in a posterior tib or a gastroc that's been sensitized, versus the local tissue response. Hey, I think this is local tissue which is irritated. Let me treat this local tissue to get this local tissue to reset. I'm someone who tends to bias toward the central nervous system, but certainly anytime you have a bias, you're more prone to overlook the other elements. So I will sometimes try and think through these different areas and kind of get a sense of, what maybe in my initial treatment, what did I see? But definitely in that second treatment, that third treatment to see, hey, what area of the system I tend to be working in and where am I getting my response? I can't always figure it out, but it's just a nice exercise to do. It also helps cement you in your mind, hey, what systems am I working in and why am I doing this?
I think the couple things to take away in my mind here is that, you know, needling works at these four levels simultaneously. So you can't really, you're not really gonna only go for the inflammatory cytokines or only go for the endogenous opioid system. It's all mixed together, and each patient, presentation kind of needs a different mixture so that their body's going to respond in a certain way. And the other piece is that needling is fantastic, but needling alone is not rehab. It's not the answer. It's a neural reset and a optimization of that local tissue healing response. But it must be paired with the things we mentioned, which is that active motion, sensory input, progressive loading, proprioception, and then that return to sport in this case for John is, you need to handle the calf load tolerance, you need to handle ankle mobility, hip propulsion, and foot stability, or else, hey, you're going to help the tissue, and then he's going to injure either something else or this tissue again.
Yeah, no. Hey, hope this case was helpful. Clean. It's pretty good. Anything else? Any parting words there, Frank? I think
That's
I
about it.
am good.
Yeah.
All right, guys, we will see you on the next one.